Well, thank you for joining us today for another episode in this multi-part series called Improving the Continuum of Care. I'm Dr. Larry Patterson with Eye Centers of Tennessee, and with me today are Dr. Mary Ann Murphy, who's an optometrist at Front Range Eye Associates in Colorado, and Douglas Leva, who's an ophthalmologist at Leva Eye Care in New Jersey. Now, as eye doctors, we've all experienced a lot of shifts in the healthcare landscape, from reduced reimbursements, EHR requirements, and all these next generation innovations in cloud connectivity, and all these things that actually enable us to reevaluate everything we're doing, our workflow, the efficiencies, staff, patient data, collaborative care. And I'm just going to be asking a series of questions around that. I'm going to start with just the whole issue of practice efficiency. And when we talk about practice efficiency, we often start talking about ourselves. But what I'd like to start off this first question is more patient centric. So, what efficiencies have you created in your practice that support patient care? Marianne, I'll start with you.
It's interesting, even thinking about patient-centric care, that used to begin with the first touch with the patient, when the patient first called the office and the data collection and, making sure all of that was streamlined. But now I think it goes even farther back than that, aside from even setting up office efficiencies, is now I'm thinking about this kind of stuff when I'm purchasing equipment. How easily can a patient be positioned in this? How easily can staff be trained to do this? It used to be we'd look at the reports and look at what data am I getting from this? And that was sufficient, right? Because there was this like data competition: who can give you more data, who can analyze the nerve at the highest resolution, who could give you the most points and the fastest visual field. And all that's important. But in the end, if you can't train a staff member to take the test, if you can't position a patient appropriately, you're constantly having to manipulate their head, it changes the entire flow of the office. So for us, it starts with equipment selection, and then all the things that you would expect, I think, Larry, in terms of, making sure you get all that data from the patient, making sure you get records from participating providers, other members of the eye care team, and then bringing them into the office with the understanding from staff that they know exactly what you're looking for. Trying not to move the patient around too much into the exam room and then finding out you need an OCT, into the exam room and then finding out you need a visual field. If we can get all of that kind of lined up ahead of time so we can use the lane most efficiently, we found that that makes a huge difference for us.
Dr. Leva?
Well, I built my first office in 1986, and after about 25 years, I built a brand new office with having had 25 years of experience. So I actually thought of how people design a kitchen and to make things that I use more often closer. For instance, we do OCTs all the time, so I made sure that was close to where my patients are. Where when I'm doing an IOL mask for a cataract calculation, I'm not going to do that as often, so that's a little farther away. So this way, my technicians and myself are right very close by, so we don't have to do a lot of walking because I do have a large office. And I also designed it as we bring the patient into the office. The first thing they're going to hit is the pre-testing room, where all the patients get an air puff to screen them for pressure. We have the lensometry, autorefractor, and then we bring them into the next room. I have actually a retinal imager where I can get a large view of the retina. So this way, when the patient is brought into the room by my technician, who takes all the history, they do the preliminary refraction. They have up on one screen my regular EMR, which has the patient information, the refraction lensometry, and then on the other screen, it will actually have, if it's a routine exam, it'll have the retinal image. If it's a glaucoma patient, they'll have already loaded my glaucoma workplace, so I can have the form, and so I can go over the results of the visual field and the OCT with the patient right there. So that has created a lot of efficiency for me. And be able to also access all my different instruments, whether it's topographer, the IOL master, my retinal camera, my specular microscope, my regular fundus camera, all that goes into form. And so it's all right there on my monitor in my exam room with the patient, being able to see it simultaneously with me.
We went through something similar because I started practice in 88, but it was 91. I built my first office. And then in 02, I built my second one and did a lot of the same things. But you'll build your office, and then we didn't even have OCTs back then. And we found a place to put an OCT, and all of a sudden you're realizing you're using it all day long. So we just did the same thing, move the OCT a lot closer to us. How do you guys see how these efficiencies have helped you, especially as a physician? How has that allowed you to improve your experience?
Well, as doctors, we're really, our patients are our widgets. And so it basically as reimbursements has gone down, to stay financially successful, we have to be more efficient. So we have to be able to see more patients per hour. So it is able to make us more efficient without degrading the quality of care that we give that patient.
Yeah, and I think that ready availability of the data, I think, like Doug said, having something as simple as having form up when the patient walks into the room, right? You know, all the data that you need is there. They're expecting you to go over it with them. They just went through this rigorous testing, and they want to know all the tests that were done. But it's something as simple as, if you get in the room and form's not open by your technician, that extra like 30 seconds to load it up just takes that much more time. So having it up and ready to go, I always encourage providers when they are purchasing Forum to, when they say, how many licenses do I need? And I'll say, how many providers do you have? And like quadruple it, right? Because it's just because you have 4 providers doesn't mean you just need 4 licenses, because you want to have it open in these other rooms and ready to get into. But being able to use some of the document display, having images up side by side, and really involving the patient in that data processing. I'm looking at these trends over time, and you're invited to participate in this care with me, because I can tell you, 10 times over that I think you have glaucoma, but if you're not willing to be treated, or you don't understand why this is important and what these trends are showing, without that patient compliance and that patient buy-in, obviously treatment becomes much, much more difficult.
In our general practice, we actually do a lot of retina. We're in a rural area, and we do probably 10,000 retina injections in our practice a year. And we don't even know how we would do it without Form, because I remember back in the old days, you would get a picture of a retinal, a macular OCT. You just have a picture, and you're looking at today's picture, static picture, versus last time's static picture. And being able to scan the last picture and side by side having today's scan to be able to and show patients, or not, just for me to look at it. I don't know how anyone could possibly. I don't know how when we look back, I don't know how we did it back then.
Well, remember, the cameras used to be film. So you take a picture, you gotta wait a couple weeks.
Yeah. I remember
some viewer that you use, instead of looking at the Grand Canyon, you look in the patient's nose.
Right.
Yeah, I remember that too.
I remember those viewers.
You both, when you think about your practice from the patient's perspective, how do you think they view this? I mean, we often, we're doctors all the time. We don't really look at it from the patient's perspective. What do you think about what they're seeing when they come into your office and go through the process?
Well, do you think it's important? Go ahead, Doug.
Well, I was thinking, I just had a patient the other day that was just in for, she has ocular hypertension, and, I just realized, when we started talking about it, she started crying. She was so upset. You have to realize, to the patient, when they hear the word glaucoma, they think blindness. So when I have a patient that I'm following for, let's say, ocular hypertension, where they don't have glaucoma, and try to explain to them why you're not treating their elevated pressure when they've heard their friends are getting treated for elevated pressure, it's very powerful to show them 10 years of data and their graphs where there's horizontal, there's no progression. I can show them a test from 10 years ago, and then they haven't had any deterioration. It confirms why I'm not treating them. I'm a big non-treater. I always quote the OAT study to patients and say, look, 9.9% of patients develop glaucoma in 5 years with pressures 24 or greater. But my perspective is 90% of people don't. So my job is to prove every year why I don't have to treat you for glaucoma, even though you have elevated pressure. So how do I do that? I have to present you with data, and that data is I have to show you that there is no degradation in either the structure of the nerve or the function of the nerve. And so when I can put up, I've had the OC since 2010, so I have 12 years of data that I can show them OCT data. Visual field, I have 20 years of visual field data that I've been able to import. Unfortunately, I don't have beyond that because it was floppy disk, but I have 20 years of visual field data, and I explain to the patients what the computers do best. They deal with numbers. The OCT and the visual field, all the data is really numbers. And so it's able to analyze all the data very efficiently. And I can put up the screen, the form, I pick the graphs that I like, and I show them how there's no deterioration. By the same token, I have patients where I can show them they're having deterioration. So this way, when I do institute treatment, they know that it's important that I'm doing that. So we want to stop any progression when we've seen this. And I'll tell you, one of the most powerful things is, now that I've had Forum for a long time and have so much data, is it's remarkable how many patients I have where, if this was the first time I'd see them, both the OCT and the visual field are completely normal. However, if I go back and we do the progression analysis, I may see that their nerve fiber has degraded. Or what's really surprising, and I've seen a lot of patients, is we're really looking at the cup to disc ratio graph, where sometimes the nerve fiber layer really hasn't changed, but all of a sudden the cup has gotten significantly bigger. And if you see the graph going from yellow 95 to 99 in the cupping, that's a real change. And so it's not always the nerve fiber, and it's not always the visual field. We have all these different parameters, so we don't have to focus it on one thing. And so we can make sure and ensure the patient that we're not missing anything. And I think if we were printing out, 30 pages of papers and this and that, and it's just not practical. When I used to print, my printers now cost about $500 to fill them up with ink. And so are the doctors who don't have Forum, are they really printing pages of progression analysis every time on the visual field? Are they printing progression analysis on the OCT? Look, our machines are capable of doing what Forum can do, but it's bulky. It's not practical. It's time consuming. Who has the time to really sit down and analyze? Did the nerve go from 0.66 to 0.68? You're going to miss it. But if all of a sudden you see the graph and it's red, you have a real problem there.
That's interesting what you said, because I'm a non-treater. I'll see people coming in on 1 or even 2 glaucoma drops. And after I do all the testing, and I'll stop a drop and see them back a month later, and their pressure is the same. I'll stop the other drop, their pressure is the same. And no disrespect to your prior treater, but you don't have glaucoma. You just, but go ahead, please. So
I'm with you on that one. I think what I enjoy most about Forum, especially in the glaucoma workplace, even for myself, is looking back and being able to document with some of the tools in there, kind of when I initiated a treatment, what the real impact of that was on both the visual field and on the optic nerve. And, I catch myself sometimes pulling back going, gosh, the more of this data we have, I can see now where there's this consistency that I wonder if we can't pull you off treatment. I never tell someone they're going to be on treatment forever. I always tell them that data changes and information changes and studies change, and we're going to constantly be looking at it and continue to keep them involved in the process. I'm also someone who is an adopter of just kind of the KISS philosophy, and so just kind of keeping it simple. I use other technologies like Rendia, which used to be iMaginations, and I break it down for them kind of in a cartoon first, because I think if you bring up a MAC OCT with an epiretinal membrane, they're like, what are we even looking at, right? You can call it a digital ultrasound or something, and they get the concept, but they have no idea kind of where in the eye it is. And I find that pairing that Forum technology with some other just high level graphics, sometimes, to your point, Doug, it takes a little bit of the personal nature out of it, where I'm not saying, hey, you have glaucoma, because immediately thinking I'm going blind, why wouldn't you treat me? But also, this is kind of, in general what it looks like, and this is specifically what we're looking for in your eyes. I definitely have patients who I think truly do have glaucoma, and together we still opt not to treat. And that's, to me, the beauty of those graphs is if I'm looking at those graphs and I think, hey, this is going to cross some sort of threshold where I think your risk for losing vision is high when you're 120 years old, I'm not too worried about it. And they're not too worried about it. And we're watching that together. Whereas if there's risk of losing vision when they're as young as 75, we're definitely going to intervene. But involving them in that process, I think, continues to be really important.
Well, doctors, I thoroughly enjoyed this. Thank you both for your insights into developing the kind of workflow that's going to support both our patients, our staff, and us as doctors. So thank you very much. And thank you for those of you who are watching. We appreciate your attention and hope this was valuable to everyone.